arterial hypertension. In this, I'll be covering all the subdivisions which are written in screen. I'll be covering all the aspect of pulmonary arterial hypertension. So first of all, we talk about basic concept. Basic concept. If I talk to you regarding what is the arterial pressure, everybody knows it is 120/80. Everybody knows, even the layman also knows. And in fact, this is the pressure what we have in the aorta. Okay, so we can say it is aortic pressure. But when we talk about pulmonary artery, the pressure of the pulmonary artery is 25/10 millimeter of mercury. 25 is systolic pressure and 10 is the diastolic pressure. This is pulmonary artery pressure. Well, simple physiology I'm talking, nothing special about it. But there is now come the catch point. Well, when we talk about hypertension, systemic hypertension to be more precise. So in systemic hypertension, when we say when the BP is more than 120 and more than 80, of course we have various division, mild, moderate, severe, pre-hypertension, step 1, vagara vagara. But normal BP we say when BP is below 120 and below 80. And whenever it is either of these is increased, we call as hypertension. Okay. But again repeating second time, more than 120, 80, of course 80 to 89, 90 to 90, 99 and 90, 100 onward are the hypertension criteria. I'm not going to talk that. But again you will ask you why you are talking like this. Now come the question. We call as a case of pulmonary arterial hypertension when the mean arterial pressure is of pulmonary artery is more than 25 millimeter of mercury in the resting state or more than 30 millimeter mercury after exercise. What I want to convey the message is, here when we talk about pulmonary arterial hypertension is based on only one figure, that is mean arterial pressure. Resting stage more than 25 and the after exercise is more than 30 millimeter of mercury. Again, when talk about systemic hypertension, criteria is either diastole or systolic pressure. Either of them is raised is we call as hypertension. So here we are talking about mean arterial pressure. So let's calculate. Well, how we calculate mean arterial pressure is diastolic pressure plus 1/3 of the pulse pressure. So in this case, 10 is the diastolic pressure, 25/10. Then 25 is systolic pressure, 10 is the diastolic pressure. I hope all of you know what the pulse pressure is, the difference between systole and the diastole. 1/3 of the pulse pressure. So in this case, 10 plus 15 multiplied by 1/3, 10 plus 5, 15. So here we are getting mean arterial pressure normal as 15. Normal mean arterial pressure of the pulmonary artery, PA stands for pulmonary artery, is less than 20. Normal. And as per our calculation that we see, usually is about 15. And now we go back to the definition. The definition says that if it is more than 25 millimeter mercury in the resting state and more than 30 millimeter after exercise is pulmonary arterial hypertension. So, and believe me, this point is not known to 99% people are not aware that the criteria of pulmonary arterial hypertension is not systolic and not diastolic pressure of the pulmonary artery, but it is the mean arterial pressure. So, a quick recap of what I have done so far. Normal pressure of the pulmonary artery is 25/10, and if the mean arterial pressure is more than 25 or 30 in resting or exercise state, is pulmonary arterial hypertension. So with this definition what we learned so far, let's talk about what are the causes, or what is the causes. We can be having primary, or primary is idiopathic. Okay, idiopathic means we don't know the actual cause is there. Secondary, we definitely have we know the cause. Cause is known. We know the cause. But pathophysiology of this is very, very important. Invariably in the exam they will ask you about this. This is the most important. So pathophysiology. So friends, let me discuss the pathology and pathophysiology. Pathology and pathophysiology of primary pulmonary arterial hypertension. Pathology and pathophysiology goes like this. Well, as I told you, in primary it is idiopathic. We really don't know what the reason behind the problem. No reason known. Second, and this is perhaps the primary or idiopathic, they say perhaps it is due to genetic reason. What are the bases of genetic? I'll discuss very soon. Genetic reason, and what the mode of inheritance? It is autosomal dominant with variable penetration. It is autosomal dominant with variable penetration. That means not fully developed. Variable penetration means in some patient it may manifest markedly, some patient it may manifest less. So that's why the word they use is variable penetration, although it is inherited in the form of autosomal dominant. Let me clarify the basic concept of variable penetration. Suppose there is one family. In one family there is one disease, any disease with the variable penetration, autosomal dominant. Let's say if it's pure autosomal dominant is there, the disease is manifesting like this. We have three children, and you can see each one of them have equal manifestation of the disease. Any disease, autosomal disease with variable penetration. Now look into one more. Autosomal dominant with variable penetration. It is autosomal dominant. Each one of the child should manifest. Okay. This was the autosomal dominant. Each child manifested equally. That you can see. But when we have a concept of variable penetration, look at this thing. Okay. So now here we have three children. One has this much manifestation of the disease. This has this much manifestation of disease, and this has this much variation. All are autosomal dominant. But now you can differentiate between this autosomal dominant, which is pure autosomal dominant, and this is with variable penetration. That means every child has manifested this dominant, but degree of manifestation varies is the meaning of variable presentation. I hope you got the meaning. So we come back. So here also, if there are 3 children will be there, or maybe 2, everybody will have different degree of manifestations there. Well, now come the very, very important question. What is the basic abnormality in the gene? The basic abnormality in the gene is, this is a question from genetics, very frequently asked question. Basic abnormality in genes. What happen in the genes? That is bone morphogenic, protein receptor 2, what we write as BMPR2. So the basic gene problem where happen is in BMRP2. In fact, it is a golden word to remember, golden word. If you are in the exam, if you are getting something called BMRP2 gene, 99% you are dealing with idiopathic pulmonary arterial hypertension, but we also write as primary, P for primary, pulmonary arterial hypertension. That means it is an idiopathic variety or primary variety of PAH. So BMRP2 is synonymous with PPAH, primary pulmonary arterial hypertension. Golden line to remember. If you get 99%, you are through. Now there is something extra which we talk about. Now in this we have a classical, again a question for you, pet question of MLE. There is a theory why this happen. This is so-called two-hit hypothesis. Two-hit hypothesis. That means now I'm discussing the pathophysiology of primary pulmonary arterial hypertension. The concept is that this problem occurs at 2 stages. Well, first abnormality to happen is the patient should be genetically susceptible. Okay? Genetically susceptibility is needed. Genetically susceptible. Now, if I asked you what are the criteria of genetic susceptibility, the patient should have problem in the PR2 genes. PR2 genes. The patient should have problem in the BMPR2 genes. That means he's genetically predisposed. Patient is there. Now, after that, second insult. This is known as first insult. First insult is the genetic basis. Now we talk about second insult. Now this patient who is genetically prone to develop PPAH. Now, whenever second insult occurs by certain infection, any infections, okay, or any other predisposing factor like some channel defects, etc. These, so any predisposing factor This will lead to vasoconstriction. Vasoconstriction. Constriction. Well, vasoconstriction, it has got lots of clinical applied. So now, based on this, let's talk about the clinical applied regarding vasoconstriction. The clinical applied number 1. This vasoconstriction is done by a substance so-called endothelin. Endothelin. It itself has got many more clinical applied. So endothelin is the one which is going to cause vasoconstriction. Now what are the clinical applied of based on this? It is the most powerful vasoconstrictor in the body. Vasoconstrictor in the body. We know very well that angiotensin 2 is also a vasoconstrictor, beyond doubt. But endothelin is the most powerful vasoconstrictor. This is very, very important point. Second clinical applied. So definitely when it lead to vasoconstriction, so BP the pressure will high. Why? Again basic concept. About this I'll be talking to you. So we talk more about this vasoconstriction, more basic concept, and regarding basic concept and the clinical applied also. So BP is equal to any BP is directly proportional to peripheral resistance. BP, any BP, whether it is systemic BP or it is pulmonary blood pressure, it is directly proportional to peripheral resistance. Next point, peripheral resistance is 1 by R4, is inversely proportional to 1 by R4. R is the radius of the arteriole. So if the arteriole of the pulmonary vasculature they get constricted, so definitely pressure in the pulmonary artery will increase, and that constriction is done by what? Endothelin. So we understood the importance of R is the radius of the arteriole. So now come the gold medal question. So definitely if we get a drug which is a endothelin antagonist, will lead to what? Vasodilatation. So we have a drug so-called endothelin, a receptor antagonist, and that is bosentan. So bosentan is used. Bosentan is used in the treatment of pulmonary arterial hypertension. I hope you can nicely correlate physiology by 1 by R4. You can nicely correlate physiology with endothelin, which lead to vasoconstriction, and that causes increased pressure, and you are using pharmacology that we are using endothelin receptor blocking drug bosentan, right? So we learned vasoconstriction. So we come back to pathophysiology, and we got one entity vasoconstriction, and we got very lovely MCQs based on this. Then there is also decrease in the nitric oxide. In fact, nitric oxide is a very powerful vasodilator. It is a very powerful vasodilator. It's a very powerful vasodilator, and in this nitric oxide level is reduced, so that further lead to vasoconstriction. So this will again lead to vasoconstriction, right? And there is decrease in the prostacyclin. And prostacyclin are again, I am writing PC. They are again dilator. So definitely, prostacyclin are vasodilator. So definitely, when the level of prostacyclin will go down, that will lead to intense vasoconstriction. So we have got three mechanisms. We got three mechanisms by which vasoconstriction occur, and ultimately, if I ask you, what will the net result? Net result will be reduce arteriolar size, or so-called radius. So radius size is getting reduced. So many-fold will be rising the pressure. So there are three mechanisms. Out of these and this, they play a major role. That's why we have used the drug so-called bosentan. Bosentan was endothelin, and prostacyclin is also causing vasoconstriction. Reduced level of prostacyclin is causing vasoconstriction. And now come the clinical applied of this also. So if we use a drug which is a prostacyclin antagonist, agonist drug, any drug which will going to cause increased level of prostacyclin analog. So drug which are prostacyclin analog, that means which are mimicking like prostacyclin, will definitely lead to vasodilatation, and vasodilatation means BP will come down. So let's clinical applied. What are the drugs which come in the category of prostacyclin analog? They include iloprost. They include treprostinil. They also include epoprostinol. These three are the pharmacology, including medicine. So they are, what the mechanism of action of these drugs? They are all prostacyclin analogs, and they lead to vasodilatation is there. So I hope you are clear about it, why we are using these drugs. Well, again, ultimate theory is regarding vasoconstriction. So now I'll add on to the other drug like calcium channel blockers drug like nifedipine. Same use. Why? It's a vasodilators. So now we understood why we are going to, in the treatment, we'll be using the drug like calcium channel blocker. Is nifedipine is a direct dilatation. It dilates the smooth muscle, right? I have one more drug, but I'll be talking to you regarding little later on. So as of now, I discuss why we are using, we correlated, why we are using endothelin receptor blocking drug, and ultimately one thing we have done in the pathophysiology, what we have learned is vasoconstriction, and vasoconstriction by reduced prostacyclin, reduced nitric oxide, and increased level of endothelin. Now, what it will lead to? Now, what the vasoconstriction will lead to? What problem it can cause? So, once the vasoconstriction occur, it lead to the effect of vasoconstriction. The effect of VC stand for vasoconstriction. It will lead to smooth muscle proliferation. smooth muscles in the coronary vasculature, of course, in the pulmonary vasculature, of course, smooth muscles proliferation. If the smooth muscle proliferate, so definitely it is going to reduce the level of lumen of the arteriole. Next, and it also predisposes to thrombosis. It predisposes to thrombosis. Why? Because the vasculature diameter is reduced, radius is reduced, so that further causes slowing of the blood flow, and that can add to the problem. Okay, and there will be endothelial cell growth. There will be endothelial cell growth. There will be endothelial cell growth into the vasculature, and finally all these will lead to pulmonary arterial pressure will be increased pulmonary arterial pressure. All these the problem what we'll have in these patients. So I hope you understood. The net result of the pathophysiology is vasoconstriction, and the add-on factor are smooth muscle hypertrophy, and this of course there will be endothelial cell growth will be there, and these can predispose to thrombosis also, right? Well, now pulmonary arterial hypertension has occurred, and if you see, now we see the histology. If you see a histological examination pathology, we get plexiform lesions in the pulmonary vasculature. If you get this word plexiform type of lesion in the pulmonary vasculature, 99% you are dealing with primary pulmonary arterial hypertension. This is such a catch point. This is almost virtually diagnostic that we are dealing with pulmonary hypertension. Now let me show you a beautiful picture also. Okay, this is normal heart, and this is the, of course, pulmonary vasculature is there, and you can see this is the nicely normal pulmonary artery. Now look at this. We are getting constriction in the pulmonary arteries. So we are getting the pulmonary artery is getting constricted, and that's the main thing. The basic problem is in the pulmonary artery, as well as down the line also, entire vasoconstriction, and that's the reason why hypertension occur, and why the entire pathology and pathophysiology is based on this line. You can see nicely, you can correlate. Here it is widely dilated, and here you can see very constricted artery is there, right? This is one thing. Now what is it going to cause? Let's learn more about pathophysiology. This is the normal heart, right heart. This is normal right heart, you can say, right ventricle. Now as the pulmonary arterial hypertension occur, that lead to enlarged right ventricle. You can see this and this, you can compare it. So here we get right ventricle. In fact, initially first right ventricle hypertrophy occur. Initially right ventricle hypertrophy occurs. Right ventricle hypertrophy means the thickness of the ventricle wall, thick wall of right ventricle. But in the very advanced stages, even the cavity size may be increased. Then we call a right ventricle enlargement. When the size of cavity of the right ventricle increases. But initially right ventricle hypertrophy occurs. But in the very advanced stages, we get right ventricle enlargement, size of the cavity may be increased. So I hope you are very much clear about the pathology and why it is going to lead to right ventricle hypertrophy and right ventricle enlargement, and all the back pressure will be there. In later stages, now let me go to this diagram, simple diagram. This is the pulmonary artery, and there is increase, there is primary pulmonary arterial hypertension. So this right ventricle hypertrophy will happen. Right ventricle cavity size is, wall thickness is there. In the very advanced stages, even the cavity size will be increased, and there may be in the very advanced later on even right atria enlargement will be there. Right atrial enlargement will be there in the advanced stages, right? So let me discuss here only. I'll discuss the other clinical feature that we are going to have. In this case, what the most important clinical finding? Loud P2. Loud P2. We all know that in second sound, again basic concept, we have it two component, A2 and P2. A2 is produced due to closure of aortic valve, and P2 is produced due to closure of pulmonary valve. Now, whichever pressure is high, if systemic hypertension is there, so A2 will be loud. But if pulmonary arterial hypertension is there, so P2 will be loud. Loud P2 will be there. Loud P2 will be there. So depending on which type of hypertension is there, that sound will be loud. So here, loud P2 is the characteristic finding. So this is a keyword to remember. If you are getting loud P2, virtually you are dealing with any type of pulmonary arterial hypertension, any type. It may be primary or secondary also. And one more thing, as the pressure is very, very high, so there may be slight regurgitation of blood. Slight regurgitation of blood from the pulmonary artery during diastole. Slight regurgitation of the blood because of high pressure in the pulmonary artery during diastole. Some of the blood may regurgitate into the right ventricle, regurgitation, and so we get a murmur of pulmonary regurgitation. We get a murmur of pulmonary regurgitation, and this murmur, there is a name, Graham-Steele murmur. This is known as Graham-Steele murmur. Steele murmur. So Graham-Steele murmur is seen in pulmonary regurgitation, which may be there in pulmonary arterial hypertension. So a quick recap of what I have done in the last few minutes. I talked to you regarding pulmonary arterial hypertension, and the basic pathophysiology is what? Vasoconstriction. The vasoconstriction is causing all the problem, and vasoconstriction is causing increase in the pressure. Why? Pressure is directly proportional to any pressure, directly proportional to resistance, and resistance is proportional to 1 by R4. R is the radius of the arteriole. So narrower the arteriole, many-fold will rise the peripheral resistance. Peripheral resistance means increase pressure in the concerned artery, maybe pulmonary or maybe systemic. The formula remains the same. So the nutshell, there is in PAH, this vasoconstriction is there, and it is occurring in genetically predisposing factor. Those who have BMPR2 genes, they are likely to get. Variable presentation is there, and we know that why we use prostacyclin analog, why we used endothelin receptor blocking drug. The reason being, they are all going to dilate the pulmonary artery. The clinical result will be it lead to right ventricle hypertrophy initially, later on right ventricle enlargement. P2 is loud, and we get a recurrent murmur, and the name of the murmur is yes, Graham Steele murmur. So this was all about the primary, and remember, we are getting in the histology, we are getting plexiform type of abnormality when we take a biopsy piece. If you get plexiform in the pulmonary vasculature, 99% you are dealing with primary pulmonary arterial hypertension is the one which we talk about. With this, I'll talk to you regarding secondary. Secondary. What are the causes of secondary? Pulmonary arterial hypertension. Secondary, we have certain cause, some definite causes there, and that is causing the increase in pressure. So what are the secondary causes? Secondary causes means any condition which lead to vasoconstriction, like chronic COPD, because they had COPD, they have a chronic hypoxia is there. So this lead to what? Hypoxia, and hypoxia induces vasoconstriction. Constriction. Okay, so any cause of prolonged hypoxia. Second is loss of blood vessel. The blood vessel are lost, like in interstitial lung disease or in emphysema. In emphysema, the alveoli are getting broken down, and alveoli are getting broken down. So that means you are getting the dilated alveoli. Dilated alveoli are there, but they will not be in touch. They will not be in touch with the vasculature. So, like initially it was like this. Initially it was, these are the alveoli. These are alveoli, and here is the some arterioles are going on, right? So now when it becomes a big when all the septa are broken down, now everyone is not in touch with arteriole. A good amount of alveoli, they don't remain in touch with the arteriole because of change of position. So that's why they are not in touch with the vasculature is there. Now come the and one more thing in this only, not to forget pulmonary embolism. In pulmonary embolism, this is the artery is the pulmonary artery, it is getting blocked. Getting blocked, there is no blood is going into the pulmonary circulation. Main artery block, all arterioles, they are not getting drag of blood, and that means again no blood. So ultimately alveoli will not be in touch with the blood vessels. Then next is some obstacle, and in this only in continuation, sickle cell anemia. Sickle cell anemia, they are also going to cause the obstruction to the blood vessel. So again, it will be a type of loss of blood vessel. But very frequently asked question in USMLE and MRCP, which pathogen? Schistosomiasis. It also lead to obliteration of the blood vessel. So that will again cause a loss of blood vessel. Then anything which lead to increase in the pulmonary venous pressure. Pulmonary venous pressure. I think in the secondary, this is the most important cause. point to be noted, it is the pulmonary venous pressure is getting increased, which in secondarily causing increased pulmonary arterial pressure. Okay. Classic example is mitral stenosis. Mitral stenosis. This you can't afford. This I'll be talking in great detail. Out of all the causes you forget, I don't mind. But if you forget mitral stenosis, that is a unforgivable mistake. But this need a lot of discussion. I'll talk soon. Next is increase in the pulmonary blood flow. Increase in the pulmonary blood flow. Now a question for all the students. Write down any condition you know of where the pulmonary arterial hypertension occurs due to increased flow in the pulmonary circulation. Quickly write down. You get 30 seconds to think. Any condition where the pulmonary arterial hypertension develops secondary to increased pulmonary flow. Quickly. Yes, I am sure you must have written the answer. Answer is any condition where we have left to right shunt, like ASD, like VSD, like PDA. And in such cases, again clinical applied. The clinical applied is in these cases, initially increased pulmonary blood flow occurs. Later on, it leads to pulmonary arterial hypertension. And later on, it leads to reversal of shunt. Reversal of shunt. So-called Eisenmenger complex. Eisenmenger syndrome. So Eisenmenger syndrome, where we have increased pulmonary arterial hypertension because of what? Initially, there's increased pulmonary blood flow. Got it? Very, very important point. Finally, there can be increased resistance, increased pulmonary arterial hypertension because of increased blood viscosity. Increased blood viscosity. Again, a question only for the student. Tell me any condition you know of where the increased blood viscosity occurs and which can lead to pulmonary arterial hypertension. Any condition you know of? Well, the answer is polycythemia. Polycythemia. The polycythemia is the one, of course, polycythemia vera also, but don't forget polycythemia occur in chronic COPD also. And COPD, and this occur due to what? Chronic hypoxia. COPD lead to chronic hypoxia, and this chronic hypoxia lead to polycythemia, and this polycythemia lead to PAH, pulmonary arterial hypertension. So number one is COPD, that lead to chronic hypoxia, that lead to polycythemia, and that lead to pulmonary arterial hypertension. So we learned so many factors which are going secondarily causing. So in such cases where we are getting secondary cause of pulmonary arterial hypertension, you have to treat the basic cause. Like in mitral stenosis, unless you treat the mitral stenosis, you are not going to make correction regarding PAH. With this background, now I tell you, again one more way of classification of PAH is based on this one more classification. This is pre-capillary, post-capillary, PAH. Pre and post capillary PAH. This is very, very important. But this you will never understand unless you know the basic physiology, pathophysiology, and many more things, medicine also and pediatric also. To understand this pre and post capillary pH, let us take example. Let's learn the basic concept. This you will never understand unless we know the basic concepts. Basic concepts. Basic concept is this is the heart. This is the pulmonary artery, which I have shown downward for better clarity. This is the aorta, which again I have shown downward for better clarity. The pressure in the right atrium is 0 to 4 millimeter of mercury. Pressure in the left atrium is around 6 to 12. Some books have written 4 to 8 also, some have written 6 to 12 also, some 4 to 10 also, some variation is there. But for easy, I am taking 6 to 12. Pressure in the right atrium is, right ventricle is 25 by 0. Left ventricle is 120 by 0. It is 0 to 10. But again, for easy calculation, I am taking 0. And this is a 25 by 10 I discuss, and this is 120 by 80 I discuss. Point to be noted that in case of aorta 120, when left ventricle 120, 120, but aortic diastolic pressure is 80 and left ventricle diastolic pressure is 0. Point to be noted. Here it is 0 and it is 10. Well, this background. With this background, so first of all, let me when we are talking regarding PAH, let me tell you some extra points. Extra point is regarding what is the pathophysiology of left to right shunt. I just mentioned to you that in left to right shunt, there is increased pulmonary blood flow. The increased pulmonary blood flow which is causing increased pressure in the pulmonary artery. What is that? Why and how increased flow occurs in the left to right shunt? Let's learn the basic. In ASD, the gap is there. Blood will flow from LA to RA, but the pressure difference here is 6 to 12 and 0 to 4. Pressure difference is very minimal, so blood will flow very quietly. So in ASD, no shunt murmur, M for murmur, and the blood flows very quietly, so there is no jet phenomena. Jet phenomena means if the blood flow, no jet phenomena, it means the blood is flowing very quietly, so it will not go and strike against the wall of the right atrium. So there is no injury to the wall of the right atrium, so there is no endocarditis. This is the basic reason why endocarditis does not occur in ASD. Well, blood is flowing from this, blood is also coming from superior and inferior vena cava. The large amount of blood comes to the right ventricle, large amount of blood goes to the pulmonary artery, and that's the reason why there is a large amount of blood which goes to lungs, and that leads to lung. So in this condition, lungs get congested. In all the left to right shunt, there is congestion of the lungs occur, and that leads to recurrent lung infection, and later on it leads to pulmonary arterial hypertension. The two things that happen in these patients classically. Now let's see what happened in VSD. In VSD, gap is here. In septum ventrum, pressure here is 120. In systole, pressure here is 25 in systole. So there is a huge pressure differences there in the systole. The blood will flow with a great speed and great pressure in VSD. So that will go, so that's why in VSD you get pan-systolic murmur. PSM stands for pan-systolic murmur. You get murmur throughout the systole. And the blood is going with a great pressure also. So you get a jet phenomena. Jet phenomena means is going to damage the wall of the right ventricle. Jet phenomena. And this reason in these patients endocarditis can occur. Endocarditis can occur. But in diastole, the pressure is zero. Pressure is zero, so there is no diastolic murmur. So there is no diastolic murmur. Murmur occur only in systole. But point to be noted again, large amount of blood has come to the right ventricle. Large amount of blood is going into pulmonary artery, and same story, large amount of blood in the lungs get congested and recurrent chest infection in VSD also. Now in PDA, we have a connection like this. Pressure here is 120 and pressure here is 25. So PDA you get murmur in systole. Diastolic pressure 80, diastolic pressure 10. You get a murmur in diastole also. So you get a, in PDA you get a continuous murmur. Continuous murmur you get it. And continuous murmur in PDA, systole and diastole. Diastolic pressure is 10, diastolic pressure 80. So you are getting murmur in diastole. So called this as a machinery murmur. Machinery murmur. But here again large amount of blood is going like this, going to lungs. Same story, like increased blood flow in the lungs, and ultimately recurrent chest infection and pulmonary arterial hypertension. So I hope you understood the basic concept. The point what I mentioned that in case left to right shunt, it's increased blood flow that lead to high pressure in the pulmonary artery. I hope you understood. So now I'll be talking more regarding pre and post capillary PAH. Again basic. This is the lungs, or this is the heart. This is the mitral valve, and the normal mitral valve area is about 5 square centimeter. When the area goes down to, and of course pressure here was 6 to 12 millimeter of mercury. When this area goes down to below 2.5, there is obstruction to blood flow. Blood is not able to flow freely from LA to LV. Why? The area is narrowed down. Definitely, just to give you day-to-day example, here is the main road. Your traffic is going very fast. At time, a police wala comes and he puts a barricade. They put a barricade. So now traffic has to go from this only, and this commonly seen that we see in all the metro cities all across the world. So now if this is narrowed down, so now all roads are congested. Traffic jam is there. Why? Because there is some obstruction to flow. Exactly same thing. There's a, that means the blood flow is not so freely. So first thing will be this pressure which was 6 to 12. Let me take it in short as a 10. As an average 10, this pressure will increase. So one of the most characteristic feature of mitral stenosis is increase left atrial pressure is the most characteristic finding. Increase LA pressure. Later on, of course, this the pulmonary vein is coming. This is the pulmonary vein is coming. Okay, and later on the pressure will increase because this left atrium cannot accommodate much blood. So now the blood will start going into the pulmonary vein. So this lead to increase pulmonary venous pressure. Increase pulmonary venous pressure. And again, ultimately, these are capillaries. So there will be increase pulmonary capillary pressure. Pressure will increase in the pulmonary capillaries. And finally, there will be increase in the pulmonary arterial pressure. So starting from increased LA pressure, venous pressure, capillary pressure, and the arterial pressure. So this PA, pulmonary arterial, increase in pulmonary arterial pressure, increase pulmonary artery pressure, in pulmonary arterial hypertension. This is occurring secondary to increase in pulmonary venous pressure. Now in MS, ultimately what we got? We got pulmonary arterial hypertension. We got this. But what I want to convey, problem is in the capillary, and the capillary pressure is there, but problem increase in pulmonary capillary pressure occur due to problem in the mitral valve, and this is a post capillary. Problem is post capillary, after the capillary. And in after capillary, what the hallmark is increase LA pressure. Okay. Now suppose we got one patient who got massive pulmonary embolism. Massive pulmonary embolism occurs. So definitely blood is not going forward. As the total artery block, all these capillaries, they will go into vasoconstriction. All these blood vessels, capillaries, arterioles, all these problems will go into vasoconstriction. And now I don't need that I should repeat again. The vasoconstriction will lead to increase in the pulmonary arterial hypertension. There will be pulmonary arterial hypertension will be there secondary to vasoconstriction. But here, problem is before the capillaries. In pulmonary embolism, the problem is before the capillaries. So in pulmonary embolism, it is a pre-capillary pathology. Pre-capillary pathology, and in this case, LA pressure is normal. It will remain as it is. There is no, so in pre-capillary problem like pulmonary embolism, the LA pressure will be normal. In post-capillary like mitral stenosis, the problem will be this thing. LA pressure will increase, and LA pressure we measure by pulmonary capillary wedge pressure. Pulmonary capillary wedge pressure is a way by which we can indirectly measure the very important question. So pulmonary capillary wedge pressure, in short we write as pulmonary capillary wedge pressure, which is an indirect measurement of the LA pressure. It will be increase in the post capillary, it will be normal in pre-capillary. Now let me give you a beautiful summary between the difference between pre-capillary and post-capillary. The feature LA pressure I just mentioned to you regarding what? Pulmonary capillary wedge pressure. In pre-capillary it will be normal, it is increase post-capillary. Now pulmonary arterial and minus left atrial pressure gradient, it will be more than 12 millimeter of mercury. It will be less than 12 millimeter of mercury. Why? How come? Well, let us see. This you have to understand very right. Pressure gradient is what was the normal. What was the mean arterial pressure we calculated? How much? 25 by 10 was the 25 by 10 was the this thing we calculated 10 plus diastolic 15 1 3. So we got mean arterial pressure was how much? We got 15. We got 15 in case of normal pulmonary arterial mean arterial pressure is 15. Now we say when the pressure goes to 25, mean arterial pressure goes to 25 when the patient has pulmonary arterial hypertension. And in LA, remember in case of post capillary, just now we discussed LA pressure has gone to, it was 6 to 12 and it goes up to 20. Increased LA pressure is the hallmark. I repeat again, increased LA pressure, which was initially I have taken as a 10, 12, 14, 18, 20. When the pressure goes to 20, blood start entering into the pulmonary vein and pulmonary venous hypertension occurs. So now let's say LA pressure has gone to 20. Mean arterial pressure of the pulmonary artery is 25 minus this will be 5. So it will be always less than 12. Less than 12. Okay. Now in pre-capillary, like in pulmonary embolism, this pressure, pulmonary arterial pressure is 25 and LA pressure is still 10 average. The difference lies in 15. This will be more than 12. So what I want to convey the message is, stop writing in case of this is the LA pressure. This is the pulmonary arterial pressure. LA pressure, pulmonary artery pressure. In case of pre-capillary, like pulmonary embolism, only this rises. Only pulmonary arterial pressure rises. LA pressure remains normal. So gap will be more than 12 millimeter mercury. Now in post-capillary, like mitral stenosis, LA pressure, pulmonary arterial pressure, LA pressure, this thing, both are increasing. Gap will be less than 12. I repeat again, this is pulmonary embolism, LA pressure, pulmonary artery pressure, this gap will be more than 12 millimeter. In mitral stenosis, both are increasing. The gap will be less than 12. I hope you understood. Now, what are the causes? What are the causes of post-capillary? Post-capillary is like mitral valve disease, like mitral stenosis or left ventricle failure due to any reason. And in case of pre-capillary, primary pulmonary arterial hypertension, pulmonary embolism and schistosomiasis, or it may be some congenital heart disease with pulmonary arterial hypertension. But out of these, primary and pulmonary embolism, they are the two most important things that you got to remember. Okay. So I hope you learned the difference between pre and post capillary. Well, on examination, now I'm talking about primary. Pulmonary arterial hypertension, which is idiopathic. Classically, it's all young females, 20 to 40 years age. Strongly, females far more than males. Okay. For the presentation, dyspnea on exertion. she feels breathless on exertion. And something very interestingly, if you examine the patient clinically, no rhonchi, no crepitation, no rhonchi, no crepitation, clinical applied. No rhonchi, you have ruled out obstructive disease like asthma, COPD. And no crepitation, that means there is no parenchymal disease, no parenchymal disease like pneumonia, etc. Nothing, ruled out. Okay. P2 will be loud. I don't think I need to repeat again. And there may be there may be murmur of Graham steel. Graham steel murmur can be there. This I already mentioned to you. Now come the pulmonary function test. This is a gold medal getting question, rank number 1 getting question is this. People invariably in that patient they will give you pulmonary function test. And if you are not aware of the slide what I am going to show you, you are bound to commit mistake. 99% students commit mistake here. What is so special about it? Let us see. What is so special? Here FEV1 is normal. Clinical applied. The clinical applied there is no obstructive disease. Remember in obstructive airway disease FEV1 was highly reduced. FVC is normal. The clinical applied. You rule out restrictive airway disease. No restrictive airway disease. We have ruled out this also. Ratio of FEV1 to FVC normal. That means again you have ruled out obstructive airway disease. Why only obstructive? Because in restrictive it can be normal. So we ruled out. So by now we have seen the PFT is totally normal. Is neither there is no obstructive and no restrictive. Then what the finding? Yes. So here we get diffusion capacity to carbon. So diffusion capacity is highly reduced. Diffusion capacity is highly reduced. So friends, what the clinical applied? If you get normal pulmonary function test with reduced diffusion capacity, and then if you are getting golden line to remember, you are dealing with pulmonary arterial hypertension. So repeating second time, normal pulmonary function test with reduced diffusion capacity is in a young lady around 20 to 40 years with loud P2 is the golden line to remember that we are dealing with primary pulmonary arterial hypertension. So young lady around 20 to 40, number 1 point. Exertional dyspnea, normal pulmonary function test with reduced diffusion capacity, you are dealing with primary pulmonary arterial hypertension. Okay. Well, in this we already seen what we are going to get it, we have done. So when we investigate the case, other than the pulmonary function test, we can see that in ECG you will get right ventricle hypertrophy as I discussed, and if you do the chest X-ray, you may find a large pulmonary artery. Same thing you can verify by echocardiography also. Treatment I told you, we give bosentan, I don't need to repeat again. We give calcium channel blocker, We also give prostacyclin analog, and we also give the drug so-called sildenafil. Sildenafil. It is nothing but the so-called Viagra. Okay, Viagra. It is used in case of treatment of pulmonary arterial hypertension. What does it do? It is a 5-phosphodiesterase inhibitor. It's a 5-phosphodiesterase inhibitor, and that leads to dilatation of the pulmonary artery. Finally, the treatment is nothing. If nothing works, patient is very in worse bad condition, then go for lung transplantation. Lung transplantation, although in theory we do talk about, but practically this is not an easy procedure because of non-availability of the donor, and of course technically expertise is also needed. So this is all about PAH. I hope you learned a lot about pulmonary arterial hypertension. Now I got some more small topics to cover up, and that is mesothelioma. Okay, mesothelioma is a highly malignant tumor. Mesothelioma. It is a highly malignant tumor of the pleura. Next, it is seen in asbestosis. Exclusively in asbestosis. That means whenever we are getting a asbestosis and mesothelioma, or mesothelioma, it is understood that you are dealing with asbestosis. It is a golden line to remember. But point to be noted that in asbestosis, lung cancer, bronchogenic carcinoma is more common. Bronchogenic carcinoma is more common as compared to mesothelioma. Got it? So if there is one patient who is working in an asbestos factory, then he is more likely to develop bronchogenic carcinoma. But bronchogenic carcinoma can be caused by so many other conditions also. But mesothelioma is the one which occurs exclusively in patients of asbestosis. And one more important point, if the patient is a smoker, and the patient who is working in the asbestos factory, the smoking will induce more about bronchogenic carcinoma. It will not increase the chance of mesothelioma. In other words, mesothelioma is not related to smoking. It's not related to smoking. Bronchogenic carcinoma is related to smoking, right? Well, after that, how the patient come to us? Usual presentation is regarding pleural effusion. Of course, it is in the pleura, it will lead to pleural effusion, and it is massive pleural effusion occurs. And so when the patient has massive pleural effusion, it will give rise to restricted picture, restrictive lung problem, lung disease, because there is problem of the lung expansion. And in these cases, even you keep on aspirating, you keep on aspirating the fluid, they don't respond, they keep a large amount of fluid keep on getting formed. So even pleural tapping is just transient relief will be there. Again the problem will arise. Well, in these cases, how we really diagnose? You do that fluid analysis. You can see this cancer cell. You can see cancer cells in the pleural aspirate. Of course, We can take a biopsy also. Now in this aspiration, one of the classical question, what is the special thing in the biochemistry, the clinical applied? One thing is in this patient, in the CS, in this fluid, pleural fluid, glucose level is highly reduced. Glucose level is highly reduced. This is a very, very important point. Of course, there will be malignant cells will be seen in the cytology. Regarding biochemistry, that glucose level will be highly reduced. Well, as far as treatment is concerned, there is no effective treatment. No effective treatment, and mortality is very high and very rapid. Very rapidly these patients die. That's why there's no effective treatment except symptomatic relief can be there. Okay. This is the, you can see the picture, what we get in case of mesothelioma. Okay. Then we talk about solitary pulmonary nodule. What is this? Well, patient comes to you and he gets a chest X-ray done. In the chest X-ray, you are getting a nodule like this, so-called solitary nodule in the chest. Of course, this can be benign, this can be malignant also, right? Simple nodule is there. So let's learn how we really differentiate between the two. Then I'll tell you how to proceed for this. So it can be benign or it could be malignant. This slide you have to write down. Otherwise, you'll be getting in the post also. But I want you to write down. So let us see what are the qualities of benign and malignant. So as I was telling you that we get a shadow in the chest X-ray. Remember, this we see, nodule we see, benign and malignant we see in chest X-ray. Write down. This we see in chest X-ray. So X-ray of a patient is brought to you. You find a nodule. Okay. Of course, that means the first thing will always chest X-ray. Now we have to find out benign or malignant. The criteria are, first is patient age. First criteria is patient age. If the age is below 30 years, more likely, underline my word, more likely is benign. But if age is above 40, more likely it is malignant. Well, I'm saying more likely. I never say that below 30 this cannot be malignant and above 40 it cannot be benign. It's never say. But more likely probability is 30 and 40. But remember, there's a gap also. What the meaning of that gap, I'm going to talk very shortly. One of the most important criteria is no change in size. Change in size. This is one of the most important criteria. Clinical applied. The clinical applied of this is, patient has just come to you. He show you chest X-ray, you see, you find a nodule is there. Okay. Then first thing you ask, do you have any previous film? Yes, doctor. I got about 2 years or 3 years back also. Show me the picture. You see both the X-rays together. And you find the size is almost same 3 years back X-ray and now size is normal. So no change in size is benign, and it is the tumor size was like this 2 years back. Now the size is this big something like that. Okay, so huge difference is there. Perhaps you are dealing with malignant. So the clinical applied, look for the previous film. Always you ask for the previous film if it is there. there, then you are lucky. You can just in a second only you can think, I'm dealing with benign or malignant. Of course, non-smoker more likely to be benign. Smoker above the 40 years likely can be malignant. Smooth border, spicule. So in this case, in benign you get a border like this. But in malignant you get, it's not a regular border, it's a spicule or irregular border, whatever you can say. Size less than 1 centimeter, more than 2 centimeter. Normal lungs, or it can lead to lung atelectasis, lung may get collapse, lung may get collapse. Clinical plight, this you can see in chest X-ray. So in chest X-ray you are getting collapsed lungs with a nodule. Then again you are dealing with, above the age of 40 years, perhaps you are dealing with malignant. No lymphadenopathy. Here adenopathy means lymph node enlarged, especially hilar lymph node. Hilar lymph node. This again you can see in chest X-ray. So friends, we are getting extra finding in chest X-ray. This hilar adenopathy may be in the lungs or maybe outside the lung also. So if you are getting a lymph node enlarged outside the lung, it's a lottery. You can take a FNAC. Here we have a dense central calcification. Here we have got calcification not very high, and if it is there, it is eccentric, not in the center. So here we have a central calcification. Here we have a calcification on the side. Normal PET scan and abnormal PET scan. Because when we have malignancy is there, the PET scan. In fact, in all the malignant cases, we like to go for PET scan. This is usually because we want to see where else the cancer has spread. So I hope you can say if so we are getting a single nodule and we have to go again. The single one, the best criteria is previous film, but I got many more criteria also. So in chest X-ray you are getting collapse, you're getting irregular margin, or irregular margin is there, and this lymphadenopathy is there, or the calcification which is eccentric. All these are going in favor of malignant. Now what about those conditions where we are getting so-called intermediate. That is the patient age is below 40, above 30 years. Borderline cases. Okay. So in such cases, we are, and of course, patient may be smoker or non-smoker. So that category we call as intermediate, where we are doubtful. Anyway, this doesn't carry any much of the meaning clinically, whatever way it be, how to investigate a case of patient coming to you with single nodule in chest X-ray. Patient say, I have got first X-ray. I don't have any previous X-ray. Patient age is 35 years. Now what to do? In such cases, you go for sputum cytology. Sputum cytology, patient may or may not have cough. Cough is there, you go for sputum cytology. If you can see malignant cell, it's a lottery to diagnose. Okay. But if the sputum is negative, no malignant cell, this does not rule out malignancy. It does not rule out malignancy. Malignancy may be there with normal sputum also. Then the next best investigation should be bronchoscopy. Of course, There is no harm in getting CT done before that, but CT chest will not give any extra feature whether we are dealing with malignant or benign. That we can see by bronchoscopy. With bronchoscopy, we can go for bronchoalveolar lavage. We can aspirate some fluid and look for cytology, and we can take a biopsy also. We can take a biopsy, and of course this is the best way to differentiate between benign and malignant, right? And if you are thinking malignancy, then PET scan can be done, but it is not the first line. Investigation is always the last, where we want to, in fact the purpose of PET is how much disease has spread in the body. That is more of a so-called dissemination of disease is for what we use the PET scan. But if you are to go, biopsy is the best answer. Okay, and later on we can even go for what to do. Treatment is it benign? It's a benign. You can leave the tumor also, nothing worry about it if it is nothing harm. But if it is creating some problem, depending on whether it is hematoma, hematoma is the most common benign tumor. Hematoma is the most common benign, and it present as what? It can come as maybe cough, or on X-ray what we get is popcorn ball. Popcorn ball picture is classically that we see in this patient on X-ray, and fortunately this occur in more of above 60 years. Okay, again I was talking to you, this never that I never say that every lesion, coin-shaped lesion in the X-ray above 40 years will be malignant. I never said it. This is more likely to see in elderly people. Okay, elderly people we can see this, and I have a beautiful photograph also, I suppose. Popcorn appearance, yeah, you can see, just see popcorn ball appearance we see here. Popcorn ball is there, but this is much better in scan. So a quick recap of what we learned today. Last minute revision points. In PAH, pressure is mean pressure is more than 25, in resting and after exertion more than 30. BMPR 2, if you are getting this, you are virtually 99.9% you are dealing with primary pulmonary arterial hypertension. Pulmonary capillary wedge pressure is normal, LA pressure is normal. Female exertional dyspnea, syncope and angina can occur uncommonly. The drug that we use is calcium channel blocker, endothelin receptor blocking drug like mesothelioma, phosphodiesterase 5 inhibitor like sildenafil, and prostacyclin analog like iloprost. And in these patients, mesothelioma, asbestos exposure, not associated with smoking, pleural effusion, we can diagnose by chest X-ray, CT scan, we can take a biopsy and no effective therapy. But one thing more, in these cases, trachea may be central. Trachea may be central, something uncommon. Why? At time you are getting massive effusion is there. Massive effusion is there in these patients at time because they are emaciated very fast. So most of the time they tend to develop bilateral effusion also. So in some cases, the trachea may not be shifted if the problem lies bilaterally. Okay, but not a very important feature. But just mention I got this line in one of the literature, so that's why I added this line. But anyway, most important is asbestos exposure if you are, whenever they will talk about mesothelioma, they will talk about asbestosis. With pleural effusion, 99% you are dealing with mesothelioma. Solitary nodule, benign malignant are above 40, enlarging more than 2 centimeter size. Compared with old X-ray, abnormal PET scan and biopsy are the features. So this all for today's, and Monday topic is acid-base disturbance. This is a universal topic, and this is one of the most confusing topic. And in every exam throughout the world, you get a lot of questions. But don't worry, I'll make this topic very simple, and I'll make you revise the entire topic in just 30 seconds. But I'll be needing about 2 hours or more to teach, and we'll revise in 30 seconds. Don't miss this class. So tomorrow is Saturday, and of course 15 August also. So it's India's Independence Day. So happy Independence Day to all of you. May our country progress a lot, and may all of you work hard in the life, and you make our country also progresses, because we are getting lovely young doctors who will make a name for the country also. This I expect from all of you. Sunday will be test, yes it will be, and Monday I'll be discussing the after class I'll be discussing the test. This is for those who joined today for the first time. Now what is schedule for this thing? Acid base on Monday, electrolyte imbalance, sodium potassium I'll be talking, glomerular disease, that is nephrotic and nephritic syndrome, chronic renal failure, acute renal failure, again the same schedule. Very important topics, don't miss them. Sequence of classes will be for those who joined today. This way we are proceeding, and those who missed, we will be coming again back to cardiology. The content what I taught you from all these books, what you read for the usual exam preparation, whatever you go and read, whatever notes you have made regarding PAH in particular, go and see any of the book. You find every material is there in my notes, right? So you no need to read anything else. This information for those who joined today for the first time. Our classes are useful for MLE Step 1, 2, MRCP, Australian exam, and for Indian students who want to get top rank in AIMS, PGI, NEET next, and those who want gold medal in any university exams. Okay. Success formula is whatever I am teaching you, you have to revise 7 times in front of your friends or colleagues. With 7 times, if you just read out like a news reader, one lecture of what I taught you, it will not take more than 7 to 8 minutes, and 7 times means 49 minutes. Go parallel, what I am teaching, read same thing. Same topic you read, not that I am teaching you pulmonology and you are reading cardiology. I am teaching neurology, you are reading nephrology. No, never. Read what I am teaching you. You have to spend only 1 hour extra, 7 minutes, 7 times, and do all the tests. Even if you are not read, don't worry, do the test and listen to discussion also. SPT, S, P and T is the success formula. I want to convert from you a ordinary star to a moon. There are millions of stars, but only one moon. This is the way, the quality I am giving to you. And I want to make you like an eagle which flies above the cloud. It can survive from -45 to +45. Same thing I have taught you A to Z. I have made you like an eagle. So it can stay in any environment. You can appear for any exam in the world. A to Z is the concept what I am giving you, starting from basic to the top. Premium classes for the premium student like you. You can very well contact me on my personal WhatsApp number, and you can very well contact, and for any problem you can contact my staff also. And just for information, today I am doing in the evening an orientation class for how to prepare for USMLE. Those of you who have not attended any orientation, you can join and you can contact my staff at this number. You can take a screenshot or you can write down. But it's useful for those who have not attended any orientation regarding MLE. For those who already attended, no need to attend.